Started. I want to thank you for being here. This is our monthly Healthcare Principles in Practice. This is targeted to all of our residents and faculty. Our objective is to address issues that are of interest and of import to all physicians regardless of specialty, and this is certainly one of those. We're very, very fortunate and honored to have the president of the Tennessee Medical Association with us today. Dr. Nita Shoemaker is a good friend, and she has assumed the helm of the largest physician organization in Tennessee, and she speaks for more than 9,000 members of the TMA, as well as literally she speaks for all doctors in the state of Tennessee and beyond. Glad to have her with us. She has experience as an Air Force doctor from 1990 to 1994. She's a pediatrician. She did her pre-med and her medical school training at East Carolina. Then she got real smart and went down to the Medical College of Georgia and finished up her formal training in pediatrics. Glad to have her with us. I held a practice management workshop last Friday. We had a guest speaker from Case Western who does this all over the country and travels around and speaks to residents. And he wanted to get them loosened up a little bit and start talking about career choices and their personal lives and those kind of things. And he started out with the question, he asked them, tell me about what would be the best day you could possibly have, and tell me what would be the worst day you could possibly have. And one young man, I don't know what program he would in, but he raised his hand, surprised me. He said, you know, the best day that I could have as a doctor is have no requests for opioids. I thought, damn, that's so true. So we're going to talk about that today, learn a lot more about this horrible problem, and we want to welcome Dr. Nita Shoemaker.
Okay, so I'm a little hyperactive, but I am going to try to stay behind the podium because it's being broadcast nationally over to Women's East or Erlanger East. So there's a fantastic book called Dreamland. I would encourage you guys to read it because you have so much spare time. And it basically kind of goes through what happened with opioids. So there was an article from, I think it was Boston University. It was a letter to the editor that was published in the New England Journal of Medicine that basically said they were doing databases on patients that had acute injuries well before anybody else thought about doing that. And they had like 300,000 people. What the letter to the editor said was, for these acute injuries and acute opioid use, less than 1% of patients get addicted. Well, then Big Pharma, Purdue Pharma, took that out of context, and that was back when you actually had to go get microfiche, microfilm to look at. You had to go and look at an article in the library. Most of you don't even know what that is. But what happened was they took that one thing and said it was a study that only 1% of people got addicted to opioids. And that's how our opioid crisis began. Big Pharma, specifically Purdue, started producing OxyContin, which was supposed to be even less addictive and supposed to be unabusable. And they actually started the process of having drug reps go to doctors and market it. They got very, very well-credentialed doctors to go all over the nation and talk about how less than 1% of people would get addicted to OxyContin. And now we have a prescription in the state of Tennessee. We're number 2 in the nation. So we have a prescription for every man, woman, and child. So we're going to talk a little bit about, that's how we got here. Then the pain medicine gurus started saying, oh my gosh, this isn't addictive, so let's just give it to everyone because we're not managing pain. And it became almost like not having Snapchat when you're 13. It was just unacceptable to not be treating everyone's pain and have the expectation that there would be zero pain. You guys deal with the little smiley faces. You deal with the pain scores, with Joint Commission, who says they didn't do it, CMS, who says they didn't do it. But basically, we all got scored on whether or not we were keeping people from having pain. All right. This was Christie. Who knows who he is? Okay, he's the president's task force, and this is their preliminary recommendation. The CDC says the most recent data is 142 Americans die every day from overdose. We must act boldly to stop it. The opioid epidemic we're facing is unparalleled. The average American would likely be shocked to know that the drug overdoses now kill more people than gun homicides and car crashes combined. In fact, between 1999 and 2015, more than 560,000 people in this country died due to drug overdoses. That's a death toll larger than the entire population of Atlanta. As we have all seen, opioids are a prime contributor to the addiction and opioid crisis, overdose crisis. In 2015, nearly 2/3 of drug overdoses were linked to opioids like Percocet, OxyContin, heroin, and fentanyl. It's an epidemic that all Americans face because here's the grim reality. We consume more opioids than any other country in the world, 99% of the world's opioids. And in 2015, the amount of opioids prescribed in the U.S. was enough for every American to be medicated around the clock for 3 weeks. In Tennessee, there are enough prescriptions written for every man, woman, and child to have a prescription because we're number 2. All right, I'm hoping this is going to be shocking. I got to walk away. Okay. So these are opioid naive people, and if you give them a prescription for 25 days, how many of them are still going to be on opioids at a year? Did y'all know that when you write a prescription for 60 days or 30 days? Okay, so how many of them are still going to be on opioids at 3 years? Okay, so this is relatively new data and something that we're going to talk about your part in this. Now, it doesn't seem to matter, persistent use doesn't seem to matter whether it's a big procedure or a small procedure. For instance, look at carpal tunnel. Okay, who even needs opioids after carpal tunnel? The hand surgeons say they don't, but I find that shocking. I find a lot of this shocking. I'm a pediatrician, I can say that because we don't write any opioids. So here's the other piece. Patients are prescribed an average of 80 pills. How many of you do that? Okay. After a month, 59% of patients weren't taking their opioids. Okay. If they reported completing their therapy, as many as 85% said they had unused pills remaining. So that means we're only 15% of the time writing the right amount. Okay. The average was 30 pills remaining. Among all patients in the study, 28% said they had 20 or more unused pills, 24% had 200 or more. In terms of storage and disposal, only 16% knew how to store their medicines. Do you guys routinely talk to patients about how to store opioids when you give them to them? 11% stored the drugs securely, 22% knew how to dispose of them, which, by the way, you can flush. Only 4% actually disposed of the drugs, though, because they hold on to them. Now, why do I care about that as a pediatrician other than 142 people are dying? Because 70% of teenagers who start on illicit drugs get them from our medicine cabinets. So even if we do a really good job and we teach everybody how to store them appropriately and how to get rid of them, we're still going to run up against the fact that people won't get rid of them. And so the answer obviously is we need to prescribe less. Now, I just thought it'd be fun to have something. This is my work in progress. So this is the overview of what we're going to talk about today, because I'd like to say this is an original plan, but it's not. I pulled from a lot of resources, but this will be my plan for Tennessee. So the top of that is the Tennessee Department of Health, the Tennessee Medical Association, the Tennessee Pharmacy Department, dental schools, addiction specialists, everyone who writes a prescription in the state of Tennessee. The entire House of Medicine is going to be part of a super summit, hopefully within the next couple of months. And out of that super summit, We're going to, number one, pool all the resources because everybody's operating in a silo and people are doing stuff at different institutions, but nobody's really talking about that and organizing it so that we can make a real change. And you see I broke it down into outpatient and inpatient and then what the legislature needs to do too. So again, the Super Summit, one big meeting to formalize everything and to study it, because what we do in Tennessee when we drop from number 2, we need to be able to send to other states. And so Massachusetts is the one that's really ahead of us, but we've got the opportunity. Some states don't even have a drug database to check yet. And so we are making strides, but this is kind of going to supercharge it. 24% of Blue Cross members in Tennessee filled at least one opioid prescription in 2015. Were there that many accidents? Okay. 1 in 5 members nationwide filled an opioid. So see, Tennessee's a little bit higher. Okay. 55% of Tennessee members were on long duration opioid regimen. And we'll talk about that a little bit. 3.8% nationally, so we're higher there too. And then 16.5 per 1,000 members in Tennessee, 8.3 Americans. So we got a problem in Tennessee. And again, Christie saying doctors write enough prescriptions. This is shocking. Doctors write enough prescriptions for every adult in America to have a 3-week supply. The opioid epidemic starts in the doctor's office and in hospitals. That was his quote. Does that look good for us? Okay. Now, I can't, I'm a pediatrician, so I got to talk about babies. So part of what's happening, and this is about neonatal abstinence syndrome, so the babies that are born addicted. So the slide on the side, medication-assisted treatment, that's the people in methadone clinics who are doing buprenorphine. And that's probably skewed a little bit just because we can assume that if somebody was already addicted to opioids and got pregnant, they're going to be placed into this clinic, right? So it's not all that. But look at the rest. They had a legal prescription as an opioid pain reliever. All right, so why are we as doctors writing opioid prescriptions for women who don't have long-term birth control? Legal prescription for a non-opioid. Okay, prescription opioid obtained without a prescription. So that's a lot of them, but still, where's the opioids coming from? We're writing them. And they may not be for them, but there's a lot of diversion. Heroin's out there. Did y'all see the new report talking about HIV is resurging because of heroin? And then that's the important part of that slide. And it tells you which counties, like the Northeast has a real issue. Knox County, East, we're not bad in Hamilton County. So here's the pressures. The Department of Justice just announced it's going to start prosecuting doctors who aren't practicing in good faith. Now, they're really talking about going over the pill mill. And they're talking about that nationwide. And multiple states are starting to sue Big Pharma. Who are they going to sue next when somebody in their family dies from an opioid overdose? And they're dying every day at our hand because we're writing the prescriptions. So the President's Task Force, they did the preliminary results, but they're going to stop paying for detox centers and fund treatment that lasts longer. There's a lot to the jail system about addressing mental illness and addiction, about paying for mental health services, because as you guys have tried to set up any kind of referral for anyone on an outpatient basis is really difficult. They're going to push all the major insurance carriers to align on quality measures. Praise God, they're going to do that in any way, but that's coming down the pike hard. They're going to gather data and make it public. Okay, so that means what each doctor is prescribing. And they noted repeatedly that if all doctors were following the CDC guidelines for pain, opioid prescribing would be cut in half. How many of you have seen the CDC guidelines for chronic pain? Look around. All right, so here's the plan inpatient. Now, I have to say that Joint Commission just released guidelines for 2018, and it's going to kind of look like this because I told them I'm kidding. They were already working on it. But so hospitals, we were going to press this, but now it's definitely going to happen because it's 2018 Joint Commission. So developing a drug stewardship program like the antibiotic stewardship program in the hospital. How many of you have had a patient that was on a lot of opioids and you weren't really sure how to manage their pain because they were on ginormous doses? And so this is really going to be somebody that can help you with that and talk about morphine equivalents, et cetera. We really need an addiction team too, because if you have somebody that keeps getting endocarditis and you have them in the hospital and then you send them right out and they're not placed in addiction, they're not placed on methadone or buprenorphine, they're going to go right out and start shooting up heroin again, and they're going to blow their valve again. So that's really, this is kind of going to bridge them. Massachusetts General has had a really good success with this. Up to 94% of patients stay in treatment. And here's where you guys come in. What we don't have is data. I'm trying to get it, but I haven't yet. We need data between specialties. We need data between each other. We need data to rank that between others in our state and national data. So for what procedures are we prescribing the most opioids? And then getting some follow-up. Are patients taking all those opioids? Are we prescribing too much, or is that just what we were taught in medical school? And then the diagnosis is, especially for primary care. Who in the room knows who writes the most opioids out of all the specialties? Primary care. Okay, what are they writing them for? Hell if I know. Because we don't have that data, okay? And that's my whole point, is we've got to start drilling down into the data, and I'll show you what I've done to try to get that. So we've also got to, and this again, joint, now that we have electronic medical records, woo, woo, y'all might not be enjoying that as much as I am, because I'm actually getting, the referrals back from people and looking at data. But now that we actually can pull off the data and see who's prescribing opioids and what and for what procedures, obviously that's much easier with an electronic medical record. And that's the first point. Again, Joint Commission is going to force this. So outpatient, what do we need to do? Well, the large medical centers need to determine best practices. We are the academic center for this region. And what we determine to be the best practice, in some, they don't like me to say standard of care, but we do determine the standard of care. And so we need to drive that, not just with to each other and compare to each other and find out best practices, new ways to do procedures, new ways to do anesthesia, some conservative treatment, and then we need to send that information out to the periphery, which was what we do for the people that refer to us. Mass General actually developed a bridge clinic to serve as a conduit. So basically, when you discharge a patient who's having an addiction issue, and I had Dr. Adams pull May, and I think he told me there were 114 people who were diagnosed with an opioid use disorder in the hospital for the month of May. So I know you guys are seeing this, but there's not always somebody to send them to. And so a bridge clinic that basically lets somebody knows how to handle buprenorphine but can actually take care of them until we can get them into services. I would love for us to develop a centralized referral number. There's something in pediatrics called TEIS, Tennessee Early Intervention, and so if I think a child's got a developmental problem, whether it's speech, whether it's physical, the parent can call this number. A team comes out, evaluates the child, and plugs them into whatever services they may need after the evaluation. Wouldn't that be awesome if we had that for addiction? And then this one's controversial, but we definitely need more doctors who know how to use buprenorphine. But we've got to decide that at the summit, because that can be an abused process too. It's not regulated enough at this point. So what I'm trying to do with doctors is launch a stop, drop, and roll campaign, which we all know. Stop the next patient that comes in and has fibromyalgia or has low back pain, you do not prescribe an opioid for. Okay. Drop. So the patients that you already have on any of those medications, you come up with a plan. And the plan is maybe a 6-month plan, but it's like, I'm going to drop your doses of opioids and we're going to try something different. And then the people that you obviously can't do that with, you talk about addiction or pain medicine and you roll them. Again, large medical centers, peer-to-peer to decrease prescribing. So I'll tell you, I hope Dr. Bolton doesn't mind me using his name, but I had this conversation with medical staff leadership, and basically the medical staff leadership wasn't as, incredibly interested, didn't get it quite like I did because it was the ID doctor and the nephrologist, they don't write opioids. But Dr. Bolton knew what I was talking about. And he basically, when I met with OBGYN, he said, you know what? I've started asking patients, how much of the medicine did you take? And he's finding out, instead of the standard 30 that he's always prescribed, people took 2. That's a very simple thing for you guys to do when you see patients in follow-up. And then start learning from the information that you get, because what we're trying to do is get rid of the oversupply. We're also going to use the THA and the CMO organizations to spread data and education. And of course, we're going to include the teaching hospitals because we've got to teach you guys and medical students the new guidelines, because none of you have seen the chronic pain guidelines yet. We got to include the Nurses Association, because like it or not, they write prescriptions in the state. The DO schools have to be educated on this. The PA schools, specialists and proceduralists, along with primary care, need to make sure that we're doing the appropriate screening before we give opioids to patients. If you have had depression, if you've had a problem with opioids in the past, or any kind of addiction, if there's that in your family, you're at higher risk. And those are conversations that take longer, but we need to have with patients, because we're not necessarily doing informed consent with them about how incredibly dangerous these products can be. And then we've got to get the data to reach out to the primary care, starting with high prescribers with the data, and say, this is how you compare, because you know we all want to be number one. That's why we're here. And so if you start looking at, your own patient data and what you're prescribing for fibromyalgia and then what somebody else is doing, it really will dial down just that. But my intent is not to make this punitive. My intent is to script doctors so that we have a different conversation. Because in Tennessee, people like medicine, and you guys know that. They come into my office because their child who weighs 250 pounds and does nothing but looks at their cell phone all day now can't sleep. And they want sleep medicine. That never goes well for them, by the way. Okay. But we've got to learn how to have a different conversation with people. And then we've got to change our mandatory prescribing education to be more diagnosis. I don't know, you guys, Doctor, I guess we've talked about that you guys may get some of that from SBMIC. This is really more about, well, it's not just we got a problem. What are you talking about? Like, what are your diagnosis codes? How do you manage those difficult patients? Educate us about that. SBMIC, do you guys know who that is? That's the malpractice carrier. They do all kinds of training for doctors, and although we only have to take the mandatory prescribing class every 2 years to maintain state license, SVMIC we take every year because they give us a premium credit on malpractice. So I'm working with them also to kind of change. Again, we still need data, and that's going to be my ask from you, my academic center. We need data about how to educate physicians to do this differently. And then again, engaging more physicians to use buprenorphine, that's a long ask. We got a lot to talk about. When you're writing prescriptions, especially if you're doing benzodiazepines and opioids, you really need to co-prescribe naloxone. Okay, those are part of the guidelines. And then we need to encourage something as simple as flipping a switch on the computer way back where, so every time you guys print out opioids, an opioid prescription, that a FDA sheet that I'll show you prints out. If it was on the back of every doctor's office exam room, guess what? It would be starting some conversations with patients. So some very simple fixes can help this. Aspert is, and I'll show you guys the website, and I'll be glad to get this stuff to you guys afterwards, but the Aspert is basically a screening tool. It's an online web tool that you learn about online, but it's basically screening patients for whether they're at risk for addiction. And then we're going to include the dental schools, the dentists, and the oral surgeons. And right now, I'm working with the orthopedist just going through the review board. But basically, we're just going to have a student call a month later and say, how much of the medication did you take? Do you know how to dispose of it? And kind of give them some education and then publish that data. All of you guys need some research information. This is fantastic research, and it's a really hot topic right now, just to find out what's actually happening in your center and then do an intervention and then measure it again and see. Just as a side note, what would you guys guess, Dr. Goins, you can't answer, how many women that come into Erlanger to deliver have a positive opioid drug screen? Guess. What percentage?
50.
It's 10%. Young, childbearing age women, 10% of them are on opioids when they deliver. I find that shocking. And then the ER and frontline prescribers, you know, somebody comes in and they've overdosed, then do we need to have either the addiction team or the ER start buprenorphine then? And definitely, again, co-prescribe naloxone. Have any of you guys been taught how to administer Narcan? Yes? Raise your hands. Okay. Okay. Part of what's happening too is everybody's realizing addiction is a chronic disease. And when you've taken the drug course, you're going to see Dr. Mutter, who's kind of our opioid czar. That's not the right title for him. He's the non-opioid czar for the governor's project to decrease opioids. And he's really the one, they started up the drug database so that you can check it when your patients are getting opioids. But the brain really has changed and the frontal lobe is affected, and it takes 2 years of treatment for that to get back to normal. So if you try to detox patients, they're just 20% of them are going to go out, shoot up, die, because it hasn't solved the problem yet. We've got to work to decrease the stigma of addiction and start treating it like a chronic disease, some of which we have to take responsibility for that we started because we put opioids out there. And then we need to do research grants to fund education. I think there's going to be a lot of money because the other thing that Christie's group is they sent to the White House to ask that he declare a national emergency on opioids because it's such a huge problem. And then we need to teach families who are who have high-risk individuals about the warning signs. We need to talk to everybody about, you know, if your child starts missing school and, you know, and isn't a big change in personality, then you need to be figuring out what's going on with them. Specifically, are they doing medications? And then continue to discuss disposal of unused medication. So again, the public education is the handouts that we can give patients. So again, there's 3 ways that you can either return stuff to the Walgreens. I think Walgreens has a disposal now. You can take it to the police station. You can flush it, or you can crush it and put it in cat litter or coffee grounds and throw it in the trash. Nobody knows that, okay? Because everybody thinks you've got to take it to the police station, so that's part of the reason it doesn't. But the handouts that I'm going to show you describe that to patients. And then the Department of Health is going to fund there's some very powerful public service announcements about, you know, just in the locker room and one kid giving another kid opioids because he hurt his knee, and how that, and then it shows you 2 years later that kid's shooting up heroin, and how powerful that is for the public. And then I'm going to come and talk about opioids in this conversation every time I can, and I'll talk in the paper, I'll talk to anybody, because I think the more we get word out about how dangerous these products are, then the healthier the population is going to be. And again, I'll encourage flyers in exam rooms about opioid dangers so that we can have those conversations with our patients, but also disposal. And then the naloxone to the high-risk individuals. And we also need to get employers involved in this, because I saw a study, I think it was 30% of employers are impacted by this. How many of you have had somebody in your extended family die from overdose? I've had 2. And then use the Department of Health again about doing public service. We need the state to do some stuff for us. And this just happened. I tried to put a check, but I'm not as good as this as you guys are. So how many of you checked the database? Okay. Did you realize at the very bottom that now you can click on all the states? There's like 11 states. Did y'all realize that? Okay. So there's 11 states. So we've all been saying, well, what good does it do Chattanooga right here on the border if we can't check Georgia, we can't check Kentucky? So now at the bottom you can check. It takes a second longer, but definitely that's something that we should all be doing. We also need the database to be searchable for quality purposes. Like if Erlanger wanted to pull off, the quality team at Erlanger wanted to pull off information from the database, they should be able to do that. Right now, pharmacies can actually prescribe naloxone, but it's not really being done. So maybe we need to make that over the counter. When somebody overdoses and gets naloxone by EMS, they now by state law have to be transported to the hospital. And the hospital has to report that to the health department, which means at the end of the summer, hopefully when somebody's overdosed, it's going to show up in the drug database when you check it on a patient. And I would hope that would make us all pause before we write the opioid that we were planning to write. And then we need to decrease roadblocks, because what we don't want is for the cancer patients and the palliative care to get caught up in us trying to shut down opioid use, because those are the people that truly need them. And then there's going to be something about recovery high schools or virtual high schools for teenagers. I haven't seen so many of that. Have you guys seen a bunch of teenagers addicted? Yeah, I don't think that's quite got here yet, but it's certainly going to be in East Tennessee. All right, so the other problem is when somebody's in a methadone clinic, that's federally protected, so it doesn't show up in your database. 40% of people who are in the methadone clinics get opioids from another source, because we can't see that they're there. So we've definitely got to unmask that and have that reported to the health department so it makes it into our database. But again, one large database. The AMA is working on this. Tennessee, I think, did an awesome job with an 11-state collaborative, but then they didn't necessarily publish it. I just sent it to you and said, oh my God, I didn't. And then we'll have to have more funding for addiction recovery and mental health services. And then the jails are going to have to be part of that process too. I am clearly focusing on the front end of the problem, and that is the back end's much more complicated. The front end is we need to stop prescribing so much. And then CMS and Joint Commission, I haven't seen what they said yet about the pain as the fifth vital sign. I know CMS is changing their value-based purchasing in October 2017 to not include pain. I don't know what Joint Commission, since they just said you need a task force about opioids, I'm not sure how they're going to squeeze us in the middle, but we will be squeezed. And then real payment for mental health services, because that's why it's so hard to find a psychiatrist or an addiction specialist right now. And then again, evidence-based treatment center and not detox centers, because they kill people. All right, so here's some resources for you, but I found some of this a little bit shocking too. Patients who have behavioral health diagnosis are 3 times more likely to abuse opioids. Opioid abusers have twice as many pain-related conditions as non-abusers. Individuals living in America's lowest income areas are twice as likely. Anybody have any idea why that is? They get on disability, and then they can afford it. And then opioid users are more likely to live in the rural South. I'm not going to be a proponent for medical marijuana. I just thought it's interesting that they have less problems with the opioids. Baby boomers are 4 times. This is a white male, middle-aged, down to high school, up to middle age, disease with opioids, and the heroin's following close behind. But it affects everyone. And then, of course, they use twice as much healthcare expenses. 32% of opioid prescriptions are abused. This is just a list of who I met with, and that's for the TMA to know I'm not wasting time. But, you know, okay, here's where you guys start writing. Supportprop.org. This is Physicians for Responsible Opioid Prescribing. It has an enormous amount of resources. It goes through how to have conversations with patients. It talks about how many opioids are out there. Just amazing, almost too much information. The AMA Task Force, again, they want everybody to use the drug databases. They want to enhance education. So everything we've already talked about. They also have, it's called In the Epidemic, but it is on the website for anyone to use. Got a lot of information. That's the CMS thing that said in October they're going to stop doing value-based purchasing. How many of you have ever seen this? Turn the Tide was the Surgeon General, the last one, not this one. This one's going to be worse because he's an addiction specialist. This is actually a pocket guide that you guys can download, but it basically is talking about what the CDC pain guidelines are. And if we're not following the guidelines that have been out for a year, we're putting ourselves at risk. This is the FDA's handout that I would love for everybody to have on the back of their door and to print off. But basically it just talks about, that there's serious risks with this and that 1 in 4 people get addicted to it. Now, that would make me pause if my doctor handed me that. At least have a conversation about it. And this is the back part of that, and it talks about if you're prescribed the opioids, when you're supposed to come back, how to lock them up, how to dispose them. It's right there on the FDA website. And this is just more resources. I think this is the NIH. Again, CDC guidelines, opioids for chronic pain. There are so many, and there's actually like a little web tutorial that you can go through, so you don't have to go to another class. You can do this while you're driving around your car. I'm kidding. And then this is the expert training. This is the training. Basically, it's just, again, a little webinar about how to screen people for addiction risk. This is the addiction medicine site. Again, an amazing amount of information on it. Almost too much, and that's why, but it's got, buprenorphine treatment practitioner locator, like who actually prescribes this stuff. And then there's a program directory, so tons of information. And then the Health and Human Services guidelines, and then Massachusetts actually linked you to Dr. Sarah Waichman as a Harvard graduate who spoke at the AMA meeting, and she's the head of the Mass General program. So, any questions? Wouldn't it have been cool if I brought like the little pocket chronic pain guidelines for you guys? Wouldn't that have been incredibly helpful for you? Sorry, fail, I didn't. But I did give you the information that it was there. So now here's my ask of you guys. Who's here? Tell me, what, OB? Okay, family practice? Internal medicine? Oh, good. Orthopedics? They don't come to meetings? Surgery? Surgery? ER? I said ER and the lights came on. That's a little spooky. Okay, so my ask of you guys, especially in primary care, is that you start thinking about research projects. You start thinking about how we're prescribing. You guys start looking at what we're prescribing for. You guys do a little bit of research on how fibromyalgia should be managed and start bringing that information forward and compare it to guidelines. You guys start looking at the chronic pain guidelines and see if we're following those. Okay, and you can get publishable information from publishable data from any of that just as a starting point as we start drilling down on what we're prescribing for. I would love to have that data too, because I've met with Blue Cross. They won't give it to me. I met with IMS, who is the drug reps get that data. They don't really have it drilled down enough so it's useful for us as doctors. We need data on what we're prescribing for and how much we're prescribing and whether or not we're following the guidelines. That's what we need data for so that we can move forward and teach doctors how to do things better. Any questions? Wow. I've never not been asked questions before. Okay. Thank you so much.
Thank you very much. How many of you are first years? Okay. You may not know this. Those of you who've been here will know this. But every spring we have a research day that has a day full of research presentations, and we also every May have a quality improvement patient safety day. Now, your program director should be nudging you on right now to get involved in research projects in your programs and also start working on quality improvement projects for next spring. And the first thing residents say is, what topic? I need a topic. I need something.
Call me.
That's what you've heard. I mean, you talk about a hot topic for quality improvement and research is this. So we've got an enormous resource here, so you need to start thinking about that and turning to your program directors for guidance right now.
And I've already talked to Dean Shack about this, and he is fully behind. I just need, as opposed to me going to every department, it would be great if you guys went and started it yourself so that I don't have to go, you know, beat everybody up, kind of get this going. All right, so
Thank
you'll
you.
have a copy of the slides if you want them, and I'm on Facebook. You can find me if you've got a question. I have all kinds of ideas for work for other people to do. All right, thank you guys so much.
Thank you.